Laparoscopic rectosigmoid resection in partially colonic obstruction. Case male 54 years old, no underlying. He come to hospital with abdominal distension and constipation for 1 week, and CT whole abdomen show upper rectal mass with partially colonic obstruction. Operative technique for surgery. Patient position and operating room setup, and port position lithotomy, and 5-port. Tumor was seen at upper rectum. First step, lateral to medial dissection. White line of told in left parabolic gutter was incised, and dissection in a vascular plane between mesocolon and retroperitoneal. When dissection is extended to splenic flexure, complete splenic flexure mobilization with energy device and care must to avoid damage to pancreas and spleen. Full mobilization of descending colon and splenic flexure. IMA was identified and skeletonized. Bare area of mesentery is divided. Ligation of IMA with hem-o-lok and bipolar device. Mesentery of sigmoid was dissect and clearly identified left ureter, gonadal vessel. Sigmoid mesentery was dissected bluntly away from the retroperitoneal. IMV is divided in a similar manner to the IMA. Pelvic dissection is continued posteriorly while preserving hypogastric nerve. Mobilization plane ultimately leads a vascular plane between mesolectal and prosacral fascia, and continued dissection to lateral both side for complete TME. Between lateral dissection, lateral ligament containing the middle hemorrhoidal vessel and splanchnic nerve branch are then divided. You must retract rectum to medially for air correct plane for preserve pelvic plexus nerve and ureter, anterior dissection plane by dissect along Dean on villiar fascia, and preserve seminal vesicle and prostate gland. Complete total mesorectal excision was performed. Proximal point of transection should be one that is well perfusion and reaches to pelvic without tension and satisfied a 5 cm margin from tumor. Sigmoid colon was division by NGIA 6 ohm intracorporeally. Suprapubic port was performed and insert endo-GIA for rectum division. Endo-GIA was applied. Indocyanine green ICG imaging has been used for securing sufficient blood perfusion to the anastomotic area after low anterior resection, is a crucial factor in preventing anastomotic leakage. End-to-end anastomosis was performed with circular staple number 29. Recheck ICG again for blood supply on anastomosis. Intraoperative colonoscopy was check leakage and see no air bubble. Suture on anastomosis for reinforcement that help reduce risk of anastomosis leakage. Soft drain was replaced. Pathology. Show adenocarcinoma moderately diff D4AN3 node 8 in 30. Postoperative day 7 is well-being. In review journal, in 27 patient with colonic obstruction was performed to laparoscopic colectomy and seen no serous complication was can complete resection with lymph node harvest. Then we conclusion that laparoscopic colectomy for obstruction is technically and oncologic feasible. And another paper, 19.3% of 1293 patient was laparoscopic colectomy in colonic obstruction, and show that lower morbidity and short hospitalization than open surgery. So we conclusion that laparoscopic approach was decrease morbidity in colonic obstruction.